This case is a 61-year-old man diagnosed with multiple myeloma at the beginning of 2015, stage 2 multiple myeloma. The patient received induction therapy with RVD. Is a combination of lenalidomide, bortezomib, and dexamethasone. And after the initial induction therapy, he achieved a partial response. And then he proceeded to consolidation with high-dose chemotherapy and autologous stem cells transplant. After transplant, he achieved a complete remission. He was actually MRD negative. But unfortunately, the duration of his response was not so durable, was not so long. He progressed clinically in mid-2016, April of 2016, so not even a year after transplant. The patient was started on induction therapy with lenalidomide, dexamethasone, and bortezomib, which in 2016 is still considered the standard of care in preparation for transplant. Maybe this will change in the near future with the adjunction of other drugs like daratumumab, elotuzumab, or we are testing other proteasome inhibitor in an induction. But for now, lenalidomide, bortezomib, dexamethasone remains the standard of care in this situation, in this case. In 2016, transplant is still a very important piece of the treatment algorithm for the majority of patients with myeloma. A transplant was introduced more than 20 years ago and questioned recently, but we have 4 large randomized studies published, presented in large meetings, showing that transplant earlier remains an important part of the treatment algorithm. High-dose chemotherapy followed by transplant allows patients to achieve a deeper response and deeper remission, and that translated to a longer durability of their response. So transplant is still very important. MRD testing is becoming very important. It's clear from many recent studies the achievement of MRD negativity translates to a longer durability of response and longer overall survival. So MRD is becoming an endpoint of many treatments, particularly for newly diagnosed patients, like in the case that we presented. So yes, after transplant, I would probably test this patient for MRD negativity. Right now at Duke, we're using flow cytometry MRD. We don't have studies comparing the two methodologies, the sequencing with the flow-based analysis. They both have pros and cons. Sequencing is probably a more sensitive test, but again, we have not compared with flow analysis. But you need to have the spacement of the bone marrow, the bone marrow sample at time of diagnosis for comparison. The flow analysis, you don't need that. So you can do it in any patients, in any situation, so is easier. But the flow analysis is also very cumbersome, and you need to collect many events to achieve the same sensitivity of the sequencing. I don't know. I don't use PET-CT routinely. However, in the future, we probably are going to see that because with the MRD, we only test a spot when we do a bone marrow biopsy, and by definition, myeloma is in multiple, is in patches, so patches areas, so is in multiple places. So the combination of MRD and PET-CT would probably give us a bigger picture. But right now it's difficult to combine the two tests for all patients. So occasionally, I do the PET-CT and I try to do MRD in all the patients after transplant.